My name is Dr. Alarita. I'm one of the senior ophthalmology residents at McGill University. Thank you for watching the next video in our ophthalmic skills series. Today we're going to be discussing how to take a proper visual acuity and as well how to write your ophthalmic history. Okay, these are two very essential skills that every practitioner should nail and should get down quickly. Okay, basically this video is geared towards medical students or elective students who want to get a better grasp on how to do these skills. As well as a general practitioner who wants to know how to take a proper visual acuity, okay? Just before we begin, I just want to throw out a few pointers, a few tips. I often get consulted from other services, whether it be neurology or ENT, that ask me, I can't get a visual acuity on my patient. I don't know how to take a vision. I don't have the right equipment. I say, what do you think this is? I mean, obviously, it's very easy to take a vision. All you have to do is just take out your smartphone, which most of us have now, and just Google Snellen acuity chart. Okay, and there you go. You have a full chart. You can have the patient cover one eye, have them cover their eye with their hand, and read the chart from top to bottom. And you can see where they land and what their visual acuity is on the basically on the side, and then have them cover the other eye and do the same thing. So it's pretty straightforward. Anybody can do it anywhere on the fly. So there's really no excuse to at least get a baseline vision. And it helps us as ophthalmologists to better triage and screen when the patient needs to be seen or not. Okay? So please, use that little tip for your next examination. So, okay, now we're going to move on to how to take a visual acuity in the eye clinic. Thank you. Okay, perfect. So now we're ready to start our visual acuity assessment. So I'm very privileged today to have one of our best medical students, Sumaya, here, who's going to be giving us a hand to be the patient for the day. So basically, to begin your exam, one of the most important things is to make sure the patient is properly positioned, okay? So make sure the patient is sitting comfortably in the chair, make sure their back is flat against the exam chair, and that they're sitting at a good height to be able to see the letters, okay? Very important. Basically next, what you want to do is you just want to make sure that your height is set up properly in the room and your distance is set up properly. So basically, when we check visual acuity, you want to check from 20 feet away or 6 meters. That's our standard. That's why, for example, when you see someone say 20/20, what they mean by that is that if a patient can see at 20/20, which we assume is normal vision, they can see what the normal population can see at 20 feet, they can also see at 20 feet, okay? Versus someone who sees 20/100 means that basically they have to move up to 20/20 or 20 feet to be able to see what most people can see at 100 feet further back, which means that their vision is not as good as the normal population. So just keep those things in mind. Make sure the patient's 20 feet away from the screen, and then you can begin your exam. Most of the time in the exam room, there's mirrors that get the distance correct, and that way you're ready and you're set up to do a proper examination. Okay, so to begin the exam, what I like to do is I take my handy dandy remote here, and this is used for the digital projector. Okay, there's a button on the top which you push, okay, and as I click it, it actually turns the projector on and off, okay, and then you're ready to start your exam once it's on, okay. And then there's multiple other buttons that you can go through. We're not going to go through all the specifics of them, but basically on the right side there's again some buttons you push that then will highlight a line of either 20/30 or 20/25 for the patient to read. And we like to test line by line, so go by a single line is the best way to test visual acuity, okay? So now what we'll do is we'll have the patient properly using the occluder. So let me show you the occluders. There's two types of occluders that we use, okay, for the ophthalmic visual acuity assessment. One is a solid occluder, okay, and one has little holes in it, okay. This is for your pinhole test, which we're going to describe later, okay. So what we have is we basically have the patient hold the occluder, okay, and you want them to hold it up to their eye, okay, using the same hand. So if I'm checking my right eye, right hand, I like to cover here on top of my glasses and make sure they cover very well and they look through the other eye. I like to start by the right eye as kind of our generic assessment. So cover your left eye, please. Okay, so here she's covering her left eye and she's looking through the right eye. It's very important that you make sure the patient's not cheating. There's often times when the patient will try to peek through, especially if they don't see very well in the other eye. This is very important in the pediatric exam series, in the pediatric ophthalmic exam. Children like to cheat and they're always going to try to cheat you out. So make sure that they're not peeking. Okay, so here She's peeking a bit, so I'm going to push it just over like that. No peeking, please, okay? Don't cheat on this exam. And can you see the screen in front of you?
Yeah.
Perfect, excellent. So then you're going to check and have her read the line of letters, okay? Once you have her read the line of letters to you, you also can check with the pinhole. So with the pinhole, she takes the other hand, same hand, and holds that against her, okay? And now she's looking through the small, tiny holes of the letters, and you want to see the pinhole should correct for any refractive errors. So she should be able to see better through the small hole, okay? So now I'm going to go through a scenario of checking the visual acuity, all right, in a proper exam setting. Thank you. Okay, now that we have the optimal exam settings, the room is dark, the lights are off, you get a good contrast with the projector screen, you're ready to check for visual acuity. So we have the patient nicely seated in the exam chair. I like to start my default exam at about 2080 or 2070 and then work my way down to 2020. Once you get to 2020 you can stop, okay? If the patient's baseline vision is worse, you can start at 20 over 100 or 20 over 400, okay? So here we have the projector at 20 over 80. I'll start by having the patient cover their left eye with the solid occluder, please. We're going to start by testing the right eye by default, okay? And so Mike, could you please read the letters from the beginning to the end?
Yeah, so C, D, Z, K, V.
Very good. Here?
R, H, C, S, Z.
Great, keep going.
C, Z, D, V, K.
Very nice. And how about these letters?
R, H, K.
Can you read the last two for me?
No.
So she misses the last two. So basically, she sees 20 over 50 minus 2 because she missed the last two letters, okay? Or another way you can describe it is that she got the 3 letters on this line. So she has 2060 plus 3, right? Because the line above is 2016, but she got 3 on the line below it. So 2060 plus 3 or 2050 minus 2. You can, your notation can be either one, okay? So it's very important to write that and write it correctly. And now, basically, we're going to try with the pinhole to see if that can correct for refractive errors. So can you please look through the other occluder of the small holes? Look through any hole and tell me if you see the letters now.
Yes. So R, H, K, S, D.
Very good. And here?
S, V, H, C, Z.
Excellent. Keep going.
K, O, R, D, H.
Very nice. Here?
N, V, D, O, K.
Very good. And see if you can get the last line here. Try your best. Try your best.
O, N,
Good.
H, K, D.
Excellent. Good effort. So she got almost all of them except for 1 or 2. So again, 20 minus 2. So that concludes the entire exam. Then you want to do it for the other eye, obviously. And it's pretty simple. It's not too difficult. Anyone can do this visual acuity exam. Okay. So let's move on to how to take ophthalmic history. Perfect. Okay, so now we're ready to perfect our ophthalmic history, okay? So what do you want to do? You want to start with a blank sheet like this, okay? Make sure the date is written and the patient's identification is clearly at the top, okay? So what I start with basically is I start with the HPI, all right? So right at the top corner, write HPI, okay? I put them in boxes just to help characterize. You want to then write about the symptoms of the patient. Start with the age of the patient, 78-year-old female, for example, with pain, redness. You want to write descriptors such as tearing, photophobia, decreased vision, as well as do they have double vision or pain if extraocular movements. Write everything here, okay? So these are your chief complaints. Next, on the right side, you want to have a whole column here of the past history, okay? So I start right at the top with past ocular history, very important. Okay, POHX with a box around it. And then write, have they had surgery before? Have they had any lasers or injections? Next, you want to write about drops, okay? What drops are they taking, what frequency, and what dose, okay? Very important. Further on, you want to write about past medical history, okay? Do they have a history of diabetes, high blood pressure, cholesterol? Very important to write all of those, as well as do they have any thyroid disease? Next, I want to write about medications. It goes along with it, okay? A lot of times you can just read the list of medications that the patient hands to you, and you'll know what type of medical conditions they might have. So write down the medication dose and frequency. Finally, you want to write allergies. Very important to know, do they have an allergy to penicillin or to sulfonamide or sulfa? This is important to know because a lot of drops that we use can cross-react with sulfa, for example, Diamox or acetazolamide. So it's important to know, do they have any allergies to sulfa or penicillin, okay? And write the allergies here. Finally, write the family history here, okay? So do they have any family history of any eye disease? Do they have glaucoma in the family? Do they have any family members with problems with the retina, retinal detachment, retinal diseases, or any family member who's lost their vision at a young age? Important to know for retinitis pigmentosa, for example, okay? So write everything here. So next we're going to move on to the exam, okay? So what I like to write for exam, you write OE for on exam, okay? Start by writing V, okay, P, and T. Very important, vision, pupil, and T for tonometry, okay? So for vision, you want to write SC or CC on top, which is with correction or without correction, okay? And by default notation, we always write right eye before left eye. So you can write, for example, here, let's say in the right eye they saw 20/20, and in the left eye they saw 20/30, okay? So write that right and left eye. Again, you want to check for pinhole tests. So just like in the previous video, write pinhole. So I write an arrow and I write PH for pinhole, and I write what is the corrected vision with pinholes. For example, 20/20, you know, with the pinhole. If they miss 2, you can write 20/20 minus 2, for example, at pinhole. Okay, so write the notation like that. Next, for pupils, you want to check pupil exam, both eyes. So write, for example, no RAPD, okay, relative apparent pupillary defect in both eyes, OU, okay, and also you can write pearl, okay, if you want to check for pupils are round and reactive to light, okay. Finally, for tonometry, you want to write how did you take the pressure in the eye? Was it by tonopen, TONO, or by tonal applanation, TA, okay, and then of course you want to write the pressure right before left. So let's say the pressure was 12 in the right eye and 10 in the left eye, okay? Very important. Sometimes we like to write 95% just to know that it was accurate when you took the basically pressure in the eye, okay? So then what we like to do, we like to move on to extraocular movements and computational visual fields. So for extraocular movements, I like to write EOM, extraocular movements, and I tend to check the 6 cardinal gaze. So write an X with a line through that, and then check the 6 cardinal gaze locations, okay? 0 means that they had a full range of extraocular movements in that area. Then you can write from -1 to -3 being a limitation in gaze. -1, very mild limitation, up to -3 where they're completely limited in that gaze. And then you can also write, like for example, 0 to +3, where +3 means that it was an overshoot in that direction, okay, for example, in patients who have different types of strabismus. Okay, so write that for the right eye and the left eye. Here's the right eye and here's the left eye, okay? Next, you want to write computational visual fields, you know, VFL, visual field. And for this, I draw 2 crosses like this, okay? And you want to check the 4 quadrants of vision, okay? In both eyes, covering both eyes, all right? And basically, what they see in that quadrant, you write an arrow for when they can see correctly in that quadrant of vision. If they can't see, you write, you know, lines like this. You darken out 1 quadrant. That means they couldn't see in that quadrant of vision. And the thing with visual fields, be very important. The notation is different than the rest of the exam. It's actually left before right. It's what the patient sees, okay? So here's your OS left and here's OD for right. It's what the patient can see, okay? So very important to do that, visual fields and extraocular movements. So next we're going to move on to your slit lamp exam, SLE. For slit lamp exam, I like to draw a picture of the eye, okay, of the anterior surface of the eye. So I draw it like this, okay, with a circle in the middle. All right. And basically you have your conj and sclera here. Here's your cornea and your pupil, okay? And then basically you can also draw your eyelids as little arrows like this, okay? Those are your eyelids, upper and lower eyelids, okay? Beside it, you can write all the different structures of the eye, be very systematic. So starting from outside in again, lid, lacrimal, lashes, okay? SC for sclera, okay? Conjunctiva, CONJ, cornea is a K, okay? Anterior chamber, iris, and lens. And then comment on each system. So, you know, lid, lacrimal, lashes, is it normal? Sclera, is it clear? Normal. Conjunctiva, is it clear? Or is there any fluorescein staining? Cornea, is it clear? Anterior chamber, deep and quiet. Okay, quiet means there's no cells. And that the anterior chamber is deep. Iris, you know, what is the pupil? Is it round? Is there any basically abnormalities of the pupil? And especially the lens. Is there a nucleosclerotic cataract, or is there a posterior chamber IOL, intraocular lens? Write it down here. Okay, so just write down what your findings are, and watch our previous videos on the slit lamp exam to get a good grasp of how to do a proper slit lamp exam and how to properly examine all the structures from outside in. You can also write on this side. For example, I like to write K for cornea clear with a little arrow to the cornea, and anterior chamber D and Q, deep and quiet, okay? So there's how you do your anterior segment exam. Finally, if you want to do, for an extra bonus point, if you want to do a more thorough or, full exam, you can do the dilated fundus exam, DFE, okay? For this exam, you're going to draw the right and the left eye, circle here. There's the optic nerve, and then you have your vascular arcades and your macula in the center. And we like to write M, V, and D for macula, vessels, and disc. Macula, you want to talk about what is the foveal reflex, okay? As well as there any edema of the macula. The vessels, you want to say, are the vessels normal, or any abnormality of the vessels in the retina. The D is for disc, so the optic nerve, the disc. Is there any pallor or edema of the disc? What is the cup to disc ratio? Very important to notate everything, for example, 0.2 for cup to disc ratio. So write all your findings there if you're doing a dilated fundus exam, okay? Finally, the last part of the exam is your impression, okay? IMP, all right? And your plan, okay? So for impression, I like to number 1, for example. What is your impression? Let's say the patient had a corneal abrasion. You write corneal abrasion, right eye, okay? And then your plan is what's your treatment, okay? Your plan is, for example, you're going to start with antibiotic drops, Vigamox, 4 times a day in the right eye. So write that down. And then 2 could be, follow up in 1 week, okay? So write that nice and clear, and very important to leave enough space, unlike what I did, unfortunately, leave a little more space than I did, to write impression and plan nice and clearly so that the next examiner or that the consulting physician understands what is going on and what your impression is and what the plan is for the patient, okay? And so you want to communicate that nice and clearly. And, as a medical student or elective student, do your best to come up with a differential of what you think is going on, and, take a jab at the impression and plan. Do your best and write down what you think is happening. And, a lot of times, as you're a learner, that's a time when you want to make mistakes, and that's the best time to learn. So if you make a mistake at the time, don't worry. We have residents like ourselves or staff physicians who are there to help and to help with your learning. So try your impression, try your plan, do your best, and finally, sign off on your consult, and that's it. You're all done. So now you've mastered the ophthalmic history, and you should be good to go for any elective or any time spent in the eye clinic. So I hope that helps, and good luck.